I'll be honest, I would tell you this is probably the most boring lecture of the semester, so get ready.
Yeah.
Okay. I apologize. Again, we have to teach you some stuff that's boring, right? You know? So, but here we go. So, what do we have to do to prepare to treat patients? So before we provide any actual care to them, we need to orient the patient. So you need to go in and technically orienting the patient is not just to person, place, and where they're at and what time it is. It's actually like letting them know who you are, giving them your credentials, why you're there, and that kind of thing. You also need to, when you see a patient, first thing off the bat, I do expect you guys, sorry, I'm on a side note right now. I do expect you guys to write notes, because I don't put everything on my PowerPoints, so I do expect you guys to be writing, okay? I would tell you that all of my test questions either come from something in my lecture or in a lab handout, okay? Anyway, sorry, back to this. So you need to personally introduce yourself. You need to use two patient identifiers. And patient identifier is their name, date of birth, or their medical record. Your book talks about that you could use a diagnosis. I'm going to tell you that I have not worked at a hospital that would ever let me use a diagnosis to identify a patient because there's too many patients with the same diagnosis. So across the board, what you're going to find is when you walk into a patient's room, you need to ask them their name and their date of birth. Okay? We'll expect you guys to do that when you're treating and doing your practicals as well. So you want to tell them what your desired outcome is for the treatment, explain what you're going to do during the treatment, tell them the risk, and then you want to interview the patient. You're not going to be doing the initial eval to patients, but we are continually, always adapting your treatment based off what people give you back. So that's the part of interviewing the patient, okay? And then you want to give them instructions on what you're going to start doing. So really before we even get in there and talk to patients, two things are happening. We're going to need to do interprofessional collaboration, and then we're going to do professional collaboration. The difference between the two is the interprofessional collaboration. This is going to say we're making the patient the center project of what we're doing, and we're going to talk to all healthcare providers that are in on this case. So it could be the doctors, it could be the nurse, and we work as a team across the board. We need to make sure we're communicating with all of those people, especially in the hospital setting when they're a little bit more acute, and make sure that everybody understands what our role is and what we plan on doing with them, okay? So for professional collaboration, that's really within our discipline. So when I say within our discipline, not just PT, but also OT and speech, as therapy in general, we need to make sure we're all on the same page. Your primary therapist did the eval. They're responsible for the evaluation and the plan of care. But we all need to be working together and communicating within our discipline as well, okay? So your book, just as a side note, your book, if you read your book, it talks about caregiver. I try really hard to not use the word caregiver. I try to specifically say therapist. Now, to me, it's confusing if you're reading the book. They talk about caregiver all the time, because caregiver in the book is a term they're using very loosely for any healthcare worker, okay, or therapist. When you are working and practicing, usually the word caregiver means that whoever is helping the patient. So, like, my dad is my mom's caregiver, right? So, just if you're reading the book, you're going to see the word caregiver. So, just know that they're talking about us as healthcare workers. Orientation. So, before you see that patient, the clinician, they need to read the chart. Okay, don't go in. I promise you, you're going to go in and work with people that don't read the chart and they go in blind. Don't do that. It's horrible, horrible. It's not good practice skills. You need to know what's wrong with that patient. I'll give you a primary example. My dad had 4 stents put in, emergency situation. I came home from school, was upset. I go in, doctor comes in the next morning. I'm asking and I'm drilling questions at him. And he finally put his hands up and said to me, I'm just a partner. I didn't even read the chart to come in here. Let's go read the chart together. Because, so you don't want to be in that spot. Think about how embarrassing that was for him to have to finally just surrender and say, I didn't even read the chart. I can't even ask you questions. You have no idea what you're doing if you go in blind. So make sure you're reading the charts, okay, guys? Introduce yourself. Verify the patient is who you're supposed to be treating. That's that 2 identifiers. Talk to the patient. Do a little interview with them. Then do some assessment, exam. Then talk about the goals, what you're planning on doing for the treatment, and what the goal is for the actual treatment just that day and for all of therapy. Have the patient agree. You need to get verbal consent for sure. They should have already gotten written consent. Sometimes you do have to get written consent. Typically, I would tell you that your PT has probably already done that, or the front desk staff has, so you don't have to get written, but you should get oral consent, and then you start your treatment, okay? Things that we have to be aware of, there are culture diversities, right? Therapists, we are going to come across people that have different backgrounds, different beliefs, and we need to be aware of those. We need to make sure we be very respectful of the differences. One of the ways to help with your treatment is to be accepting and to be open and communicate. You need to understand the cultural norms for a patient can help you. Sitting down and communicating and developing respect for the individual as well. All right. Seeking to find common ground is going to be helpful for you, and it will help with your treatment plan. One culture difference that the book does not talk about, they talk about race and gender and all those. They're kind of like our standard that we think of when you come right off the bat. But something that they don't go into a lot of detail about is probably obesity, okay? We have a really prejudged mentality about obesity in this country. We think that people are either lazy or they're not trying hard enough. And so I would caution you to recognize that you might have that feeling and try to find common things that you can relate to that person about, okay? I hope you guys know what HIPAA is. Like, isn't it, I mean, every time you go to the doctor, you got to sign a form, right? So I think y'all are going to know HIPAA. So HIPAA is a privacy rule. It went into effect in 1996. It protects individuals' health information. That includes where it's transmitted to, and whether it's electronic, oral, or paper form. You've got to be really careful. You can't stand outside a patient's room and talk to your colleague about a patient and let other people hear you, okay? You need to be in a designated area that's for staff only. You need to be very conscious about this. I would say that probably, and then as far as the written part of the documentation part of this, most of the time, your front desk staff, or if you work for a bigger hospital, they have people that you have to ask in writing for your chart, and they do all that back ends. But also remember that people have access to my chart now, and so they can live see what you put in the chart. So, but you want to be really careful that you're not the one letting that information go. The one thing that I always find is odd, payment information is also included in HIPAA. So it can be for anything in the past, the present, or the future. It's covered under HIPAA. So, advanced healthcare directories. The Living Will is the one you're going to hear a lot about when you're working. Living wills are a set of instructions that appoint somebody the right to make a decision if that person is no longer able to, or ill, or sick. Okay. The standard advanced directory or directive provides instructions on exactly what they want done. The living will, two physicians have to say that the person is medically unable to make their own decisions safely. Okay, so for a living will to be used, you've got to have two physicians that sign off on that. So for a power of attorney, that you're appointing somebody to make the decisions on your behalf. You need one physician must conclude that the patient is not able to make their own decisions safely, and that they medically need, or it's okay for someone to be doing it for them, and let the power of attorney do that. All right. So if you ever gone into the hospital, they'll ask you if you have a living will, right? There's paperwork that you can do. You can actually, for a living will, you fill out the paperwork. Once the patient signs it and once a witness signs it, it is legal at that point. You do not have to have a lawyer to have a living will or in effect, okay? Elements of informed consent. Before the initial treatment of the patient, the healthcare provider is responsible to inform the person about the proposed treatment, any alternate treatment, and any risk from going under or doing this treatment, okay? The patient has the right to either consent or actually say no. They always have the right to say no, that they don't want it, okay? You must present, when you're asking for consent, you have to have it in a language that they can understand. You have to provide an interpreter if they need one, okay? The other thing is healthcare workers should not state or give certain results will happen from whatever we're asking them to allow us to do. So I'm not going to tell my patient, let me do, I don't know, ultrasound because it won't make you better for sure. Okay? I can't guarantee that, right? Principles of documentation. We actually have two lectures, so this one's going to be quick. 2 lectures later about documentation. But things that have to be documented for our field are going to be the initial eval, every visit, re-evals, your primary treatment and the diagnosis code need to be included, a physician's order, any barriers that you see, consent for the treatment, the plan of care, which will include their short-term and long-term goals, the frequency of the treatment, and treatment goals, and then any risk, okay? You want to make sure when you're documenting, you want to document every visit. I have worked somewhere that they didn't want to do daily notes, and I was literally floored. I was like, how are you going to get reimbursed? So I would recommend, best practice is always to document every visit. Make sure you sign and date it. Now everything is computerized, so a lot of times that's already done for you once you put in your code or your password. So, but you want to make sure you sign and date everything. Record anything significant that's different, any status change for their treatment, as well as the goals, okay? The other thing that we're going to spend a lot of time later in the semester talking about is abbreviations. You want to make sure you use correct abbreviations. Most documentation and programs, so if you've heard of like Epic or any of the big ones, they're based off of a model called the problem-oriented medical record. a guy by the name of Lawrence Wee developed this concept. The concept is that a problem is you focus on the problem that the patient is having, and everything moves around that. Okay, so that's what problem-oriented medical record keeping is. So it's kind of a broad term that we're focusing all of our efforts on this one problem that the patient has. Okay. We will go over in a later lecture SOAP notes. So SOAP notes is the way, the easiest way to teach you guys documentation. So, and then when you are out in the field working, you will use whatever program that facility has to document. But all of it comes back to pretty much these 4 categories. So the subjective is what the patient says. The objective is what they did during the treatment, and like any tests or measures that you complete with the patient. The A is for assessment. That's your interpretation as a therapist, as a clinician, on what you observed them doing, how much help they might have needed, and how they're progressing. And P is finally the plan moving forward, like what we're going to do the next treatment. Are we going to discharge? Do they need assisted devices and stuff like that? We go into a lot more detail later. So your book talks about entering corrections. If you're on paper, and I cannot think of a place that I've worked in the last 10 years that I've been on paper at. Maybe there's one out there, I don't know. If you were to write a note and you make an error, the correct way to address that is to write a line straight through it, your initial, and date it. And then make your correction, okay? Now with the programs, you have to put in that you're correcting it. It'll ask you to re-sign a password to it. That can all be audited. So if you go in and change a chart, it's all audited and it shows people what you changed and when and where and what time and day did it. So, but your book talks about making corrections. So in case anybody finds somebody on paper, I don't know, there might be somebody out there, I don't know. But record functional oriented objectives and measure data. So this is, again, we want to make sure that we are, when we're documenting, it's really important to get our insurances to pay and reimburse us. So like Medicare wants to see objective measures. So this is where you're going to be doing special tests. You'll hear about us talk about special tests a lot later. But this shows how we are using standard tests to show that the patient is improving, okay? We want to make sure that it's important for you guys to learn those tests so that everyone is completing them the same way. So if I treat and then like Logan follows behind me the next day and does the same test, that we would be getting about the same answer, okay? So that's really important as well for documentation stuff. Principles of patient management. The big thing is differential diagnosis. You'll hear a lot about this now. So patient exhibits a symptom that could be, it has the same symptoms of 2 different diagnoses, okay? So physicians traditionally had the legal right to diagnose. However, now PTs have been given the legal right to diagnose within their scope of practice. And so it depends on the state whether they're allowed to diagnose or not. But the components of differential diagnosis is the patient comes in and they have symptoms that could be of 2 different illnesses, okay? So an example of this, probably the number one you would see in outpatient, is the patient comes in with back pain. So it's an older gentleman, maybe he worked constructions, and he says he's got low back pain, okay? So you guys will get to spend a lot more time with the patients than your primary PT, so you kind of have to, in the back of your mind, it won't be within your scope of practice to diagnose, but if you don't feel like the symptoms are adding up, you should let your PT know. So patient tells you, I got low back pain, and then after spending a half of treatment with him, that he starts opening up and talking more, and he says, the pain wakes me up at night. And I've also lost 10 or 15 pounds in the last 2 months. Those are 2 red flags that he could have cancer. So at that point, you should be like, ooh, maybe this isn't just low back pain. Maybe this is cancer. For an older gentleman especially, it could be a sign of prostate cancer has spread. And so it was not caught. Prostate cancer is notoriously to be slow. It's not always caught early. And then by the time we catch it, it's in the low back, okay? So that's why differential diagnosis, you as a clinician, you will need to be kind of watching and observing for that as well, okay? And if that situation was to happen, you would need to call your primary PT if you're not right there, okay? All right, patient management process. We're going to review that chart, right? We're going to talk to our patients. We're going to get their subjective. We're going to do some of our objective data. We're going to do our treatment with the patient. Many patients will receive only a few treatments, so it's important for us to remember insurance could be a significant barrier for us, and so keep that in mind. It's something that I would definitely tell you to talk to the patient about, because they might be limited. They only might get 2 or 3 visits. That's like huge now. And so you need to be very aware of the constraints. So the frequency might be changing. So, and it's a huge barrier for our patients. We want to make sure we're implementing the plan of care, considering our discharge, and you want to make sure you don't document that the patient is able to do just something functional, like, or just the objective measure. So when I say that, I mean, I don't want you guys to document the patient can raise their arm 90 to 100 degrees. Because the insurance company is going to read that and say, sounds great, he can raise his arm, what's the problem, right? You need to say, patient can raise the arm 90 to 100 degrees, but is unable to lift their arm above their head, which they need to be able to do for work. Okay, so you've got to give more information than just that fine objective point, okay? We are constantly reevaluating the patient throughout the treatment, and then we want to make sure if the patient needs a referral to somebody else, that we help that occur. We also want to make sure we're educating the patients. If you were in Dan's class, his lab yesterday, you guys started talking about evidence-based practice. Evidence-based practice is we're trying to use the best practice skill that we have, which would be finding good research and using what our research databases tell us and the articles tell us to do as for a treatment plan, okay? So you want to use the most current and valid research. Should be your clinical decision making should always go off of evidence-based practice, okay? So when I think about this, you're gonna have older therapists that don't know how to use the internet really well, right? And then you guys are nice and young. You guys should be the leaders when you go out of school on how to find good evidence, okay? Dan is gonna start in his class starting to talk about this, but finding good research articles and then changing your treatment based off of that. A great example is when I came out of school and made it to Montana, they were using wound care. They were using Whirlpool for wound care out there. That was outdated. There was a ton of research that showed it's actually very detrimental to the outside border of a wound. And so a doctor ordered it, and I said, can't do that. So I went to the head of the department, pulled up 2 research articles, and said, this is why we really shouldn't do this for the patient. It's actually going to hurt them in the long run. So we ended up stopping more home care at that clinic because of it, okay? So it's very important. Think about if you were the patient too. Don't you want that your physician or your therapist to be doing what we have proven is the best course for you? That's what we want to, right? So that's what evidence-based practice is. Guidelines for patient exam and evaluation. Again, you guys don't do the eval, but you're continually evaluating them throughout your treatment, right? So you want to make sure you're gathering information from them. That's that subjective part. Observe the patient. And you're going to palpate, do any of your tests. You'll test cardiac function, all those kind of tests, and then make a review for your plan. So pretty much hit all those points on this slide as well. Big thing to know is PTAs during every treatment you should include some type of measurement, some objective kind of finding that you did during your treatment. You should talk about how the patient is progressing and responding to their treatment, and revise and modify how the plan of care is going. Talk to your PT if you need to. And then the plan for discharge. You should always be thinking in the back of your head, discharge, okay? I say this, my grandma loved to go to a chiropractor, loved it, okay? She'd go every week, he'd adjust her every week. I have no problem with a chiropractor. I think adjustments need to happen sometimes, right? However, I didn't like that he wanted her to come back and back. She went for like 30 years, no joke, his entire career, okay? We don't plan on having our patients that long, right? So we should always in the back of our minds be, what do I have to do to get this person back to their life, what they need to be able to do, and be planning a discharge in our head, okay? So we want to make sure we're doing patient and family education. Make sure you answer all their questions, be professional, communicate in a way they can understand. Make sure you're listening, and then we also want to give them a home exercise program. Home exercise program, you will be creating probably an account. If you haven't already heard of it, it's called hep2go.com. That you gotta have a free account there. If you guys want, I would just tell you to go ahead and sign up and get an account. We'll have a ton of exercises, so later in therapeutic exercise class, if you already have an account, you can look up some exercises. It might be helpful.
What's it called again?
It's HEP2, the number 2, go.com. And it's free. I can't remember how many home exercise programs they allow you to save within your account. It's like 1 or 2. So anyway, creating a home exercise program, you need to determine the need for continuing the treatment once they go home. So the exercises, you want to make sure you talk to them about frequency. You guys, I cannot tell you how many times I've had a patient, I gave them exercises, and I said, do it once a day or twice a day. And they come back and they're like, oh, I felt so great. I did it 4 times. Now I can't move my arm. Yeah. And I'm like, you did this 4 times a day for 3 days in a row, and you wonder why you're sore? And so talk to them about frequency as well within your home exercise program. You want to determine what kind of environment and what they have available. So sometimes we need to have them do exercises. We have nice hard mats. Are they going to end up doing it on a couch, or are they going to end up doing it on a bed? Because that might make a difference on what kind of exercise you end up giving them. So seeing what kind of environment they're going to have. You want to instruct them, show them, have them do the exercise. You want to make sure you do this before discharge. You also, I would recommend that you do it on one of your first treatments. Give them a home exercise program. Then the next time they come in, have them show you that home exercise program again. I remember distinctly, I had this lady that did bridge. I gave her a picture of the bridge. We did the bridge. I drew a stick figure for her. And then I even said, how would you describe this? Tell me the words on how to describe this. So I wrote it. Okay? She came back in. She wasn't doing anything like a bridge for number 2. Like, I was like, what was that? Like, so we did it again. So now you guys have cell phones. Everybody's got a cell phone. I usually ask the patient, can I use your cell phone and take a picture or a video for you of this exercise? And I literally use their phone, video them, and then hand it to them as well. But you need to give them a written form, a piece of paper, okay? But for those visual learners like me, that video sometimes helps, okay? On this slide, that's a screenshot of HPT, or HEP2. The big thing about this, we've kind of pretty much talked about all those points on here. Make sure you educate the caregiver as well. And the other thing is you need to document all of this and you need to put this in the chart, okay? Because if I'm the therapist that sees the patient next time and then the patient comes in and says, I have questions about my home exercise program, I'll be like, great. What exercises do you have? If it's not in the chart for me, I'm going to be not very happy, okay? So make sure you leave a paper copy in the chart, okay? Communication. Remember that verbal communication is important, but actually nonverbal communication, body language, makes up 93% of our communication and how we interpret how things are going, right? Facial expressions, your body mechanics, the position, how you turn. If you guys are slouching and your heads are down and you're not looking at me, I pretty much know that you're tired and you're done with the lecture, right? We need a break, okay? So I'm reading your body language all the time too. So remember that nonverbal communication is huge. It is easier to interpret nonverbal communication than actual spoken language, okay? Remember that your tone of voice matters, your volume. Think about your mom or your parent, whoever helped you grow up. You know their tone of voice, right? And when mama yells at you, you know you better listen, right? So the tone of voice does really matter as well, and how loud it is. Use attentive listening skills is very important. Try not to interrupt the patient and try to not answer for them. I did stroke patients for a very long time, and especially right after somebody's had a stroke and they're trying to get those words out, it's sometimes like, hey, we gotta go, and you're trying to tell me something and you just wanna like say it for them. Don't. Let them speak. They're trying, they're working really hard. Let the patient speak. I'll be brutally honest too. If you listen to your patients, they will tell you what's wrong with them. They will literally tell you. You can figure it out if you will stop and listen to them. It also can very much help diffuse a situation. A primary example is I was subbing for the day. I was doing PRN work. I was at a rehab hospital. Patient wasn't downstairs where they're supposed to be. I go up to this room. Wife is livid mad. Patient is livid mad. He has torn his Achilles in therapy that morning, and he is ready to sue. They are on the phone with a lawyer. It is not good, and I had very little information on what happened. So I sat down, calmly talked to them, told them what I could do, asked them what they needed from us. Diffuse the situation enough, sat there and listened, spent 20 minutes. Can't bill for any of that, okay? Right? My productivity tanked. But by listening, I then went and got the director of nursing, the director of rehab, told them what was happening, told them I had promised the patient and the family that they would see them today, and I'm going to deliver, so you're going to come with me, and we're going to go talk to them again. Diffused it, and that was enough for them to back down. They didn't sue. They said we felt like we were heard. We understand that what happened in the morning was an accident, and they were okay after that. Okay? So listening really does pay off. Okay? All right, we're almost done. Hang in there. Barriers. for a good communication, usually it's a loud environment, lots of movement in the background can be distracting to patients, physical distance, hearing loss. If you have bad handwriting or your home exercise program is in some kind of language that they don't understand, as in like you're talking about the muscle and they don't know what that muscle is, that's a reason for a bad communication could happen, right? Age difference could also be caused because we have, every generation kind of has their own little terms that we spit out, right? So you just make sure you're using good communication skills, good eye contact, and good documentation skills, okay? We kind of talked about this earlier, 2 slides back, but guidelines for communicating with people that have a disability. We don't want to interrupt them. We want to avoid correcting them or trying to interpret. Let them speak, and be patient during the conversation. We'll let them give you feedback, okay? Try to be respectful, greet them, and introduce yourself is also good. The final part of this chapter, they talk about hospital emergency codes. I'm not going to ask you one of these on the test. I just want you to know that they're there. So I expect you guys to read through this slide, because if you do go work at a hospital, they might have these codes. Usually they're on the back of a name badge. Usually red is fire, code blue is like a heart attack or something like that. They're going to have code color. When you go through orientation, they will tell you that, okay? I'm not going to ask you to know those, because they're going to be changing depending on the facility you work at. Medical errors. Okay, medical errors fall into 2 of the 4 categories. Every error is 2 out of 4 categories. Okay, so you have the centennial event or potential adverse. So, and then you can have an active error or a latent error. The difference is for, I'm like blanking, y'all, centennial, right? Is that right? Am I saying that word right? Okay. Anyway, we gotta get this. The centennial event is due to medical management. So think about a lift system. If the lift system is up in the sky and it's not screwed in correctly and the patient gets dropped, that is caused by the management of our healthcare facility, right? So that would be that error. A potential adverse event, there's no actual harm. That's usually a close call. The one I think about for that is if a nurse is about to give medicine and scans your bracelet, and then it pops back and she scans the medicine and it dings and says no. That's a close call, right? So nothing actually happened to the patient. And maybe that was because it's the wrong patient. Maybe it's too early for the drug or something like that. So we have a lot of things that help us now, but that would be considered a close call, okay? Severe harm, that's usually caused by an individual, and it usually happens, and it happens right away. A latent error, usually the harm is caused, it might come on slowly. So the one I think about for like a latent is, let's say I put a heat pack on you, and it didn't feel that bad at the time, but later you have a burn that shows up. That would be the latent error, okay? So hospitals, because of medical errors, they've come up with the 5 rights for medication. We don't administer medication. Your book talks about it, but this is supposed to help us not give the patient the wrong medicine, so it's called the 5 rights. The right patient, right drug, right time, right route, and right dose, okay? Preventing medical errors. Usually facilities, especially since Joint Commission has started this, they want us to use something called a root cause analysis. This is a way for us to evaluate what caused the error and go through and figure out how we can change the process to help the patients, okay? It will usually address what kind of error it was it equipment, and then was there an obstacle that caused the problem as well, and then it analyzes like the data sheets, like if it was because of a chemical or something along that lines as well, okay? Safety recommendations, the big thing for us is gonna be hand washing. So next semester you get to do hand washing with me. You wanna make sure we're maintaining a safe environment. We want our patients to walk in a safe environment as well without obstacles. I always find that ironic because as they get better, then we need them to actually walk around them. But anyway, for safety reasons, we try to make our transfers, so we want to make sure we have anything out of the way that we can. We want to keep the floors clean and safe and dry. And you want to protect your patients. Prepare your treatment space ahead of time is probably one of the biggest things you can do. And then make sure you're trained and qualified. Your facility that you work at typically will make you do competencies every year. Joint Commission is one of the people that really regulate a lot of this. They have a survey team that comes out to facilities. Most facilities want to be Joint Commission certified. So they come out and they go through a patient. They usually follow them through. They start them like if it was a hospital. Patient walks into the ER, they stay with that patient through the discharge. So the patient goes to ICU, they go to surgery. They're going to go through every part of that chart. They're going to look at ethics, the rights, responsibilities, make sure that we followed all those. They're going to make sure the medication was managed correctly, make sure infectious disease was followed as well, and then they'll talk to leadership and go through all the medical staff. So if you're ever working, you'll hear about Joint Commission coming, and that's what they're going to be doing. Okay. If you want more about Joint Commission, there's a short little video that I included for you. Their big thing is they're trying to improve on accuracy of patient so that we don't, so we identify our patients correctly, we don't do a surgery on the wrong person. We're using good communication, we're following safety things, and that our healthcare patients aren't getting infections from us and we're not getting infections either. And then that there's no patient harm for falls or drug interactions. And the other big thing that they really look at is pressure sores. Okay. You survived lecture 1. I tried really hard to get you out on time. I'll see you guys in the back. If you're in my lab today, that back room is our lab this semester. Okay?